హాయ్ వెల్కమ్ టు కే సంవాద్ విత్ మీ మిర్చి హేమంత్. అండ్ ఈరోజు మనము అసలు హెల్త్ గురించి మాట్లాడడానికి ఒక గెస్ట్ కాదు, ఇద్దరు గెస్ట్లు ఉన్నారు. ఒకళ్ళు డాక్టర్ నాగిరెడ్డి నాగేశ్వర గారు, అలాగే జయచంద్ర గారు. సార్ వెల్కమ్ టు ది షో.
థ్యాంక్ యూ.
లైక్ ఐ సెడ్, మాకు చాలా డౌట్లు ఉన్నాయి సార్. సో మీ ఇద్దరు ఈరోజు చాలా ఓపిక్గా మాకు అన్ని ఆన్సర్ చేయాలి. అంటే మీరు ఎలా అయితే పేషెంట్స్ ఫ్యామిలీకి మీరు అన్ని ఎక్స్ప్లెయిన్ చేస్తారో అలా మాకు కూడా ఎక్స్ప్లెయిన్ చేయాలి ఈరోజు. సో ఐ హోప్ యూ ఆర్ రెడీ ఫర్ ఇట్. ఎస్
షూర్.
సార్ ఫస్ట్లీ రాఘవ్, నేను మీ దగ్గరికి వస్తాను. మీరు ఈ కార్డియాక్ ప్రొసీజర్స్ అన్ని చాలా చాలా చేస్తారు, ఐ టోటలీ గెట్ ఇట్ సార్. కానీ చాలా సార్లు కామన్ గా అంటే బై ద లెఫ్ట్ హ్యాండ్ లో చేసేసి అంత కామన్ గా ఈ మధ్యకాలంలో చేసేవి ఏంటి, మీ దగ్గరకు వచ్చేవి ఏంటి?
No, most common surgery is bypass surgery on the heart.
అంటే మై క్వశ్చన్ వాస్ అసలు why did it become so common these days, sir?
It's because it's a lifestyle disease. More and more people are there, and as Indians, we are more prone for atherosclerotic disease genetically, and diabetic burden is so high.
Okay.
So Hyderabad is considered as a capital for diabetes, and the coronary artery disease burden also is very high for us as Indians.
Right.
And
that's what when you say lifestyle disease, I think బాడీలో ఉన్న ప్రతి పార్టీకి that directly affects, I guess. Yes.
yes.
Also, sir, first I want to, నేను ఈ వర్డ్ విన్నాను, pneumothorax, yes, which is more or less lung mass or that kind of surgery. So please walk us through this, sir. So what is this? How is this? How should this be treated and etc.
న్యూమోథొరాక్స్ అంటే బేసికలీ ఎయిర్ ఇన్ ద చెస్ట్ క్యావిటీ.
Okay.
Normally it is supposed to be within the confines of the lung.
Okay.
When it escapes from the lung, either because of a tear or a puncture, it escapes into the chest cavity.
Okay.
And thereby, causing a pressure on the lungs, and the lungs tend to collapse
Okay.
on the side in which it is involved. That is basically a pneumothorax.
Okay.
This can be occurring spontaneously in some youngsters, or because of some smoking related bronchitis in the vallaki, it could occur. But when it occurs, if it is a significant air leak, it can be an emergency.
Okay.
It is not a tumor or any related thing. It is a basic defect in the lung which causes the lung to escape into the chest cavity.
Okay.
That is what it is.
బట్ ఇది కాకుండా జనరల్గా ఈ లంగ్ రిలేటెడ్ సర్జరీస్ ఇంకా ఏమేమి ఉంటాయి, ఎలా ఉంటాయి సార్?
Surgeries అంటే ఇప్పుడు suppose a part of the lung is deceased.
Right, sir.
If you think medically it's not recoverable, then we may have to remove that part.
Correct.
Whether it is infected or destroyed or a tumor, whatever. That we call it resections of the lungs. Whether it is a small part or a particular lobe. The lung has got multiple lobes, 3 on the right side, 2 on the left side. Sometimes we remove a part of the one lobe we remove. We call it lobectomy. Suppose tuberculosis, if it affects severely, one side lung may be totally destroyed. If we remove the entire lung, we call it pneumonectomy.
Right.
Sometimes floral based surgeries.
Correct.
As we said, sometimes there are what is called small air bubbles called bullae.
Right.
So we remove only those bullae which are causing the problem.
Okay. Got it. సో అగైన్ కమింగ్ బ్యాక్ టు యూ సార్, ఈ మినిమల్లీ ఇన్వేసివ్ సర్జరీస్ అంటూ ఈ మధ్యన మనం చాలా వింటున్నాం కదా సార్. టెల్ మీ వాట్ రోల్ డూ దే ప్లే ఇన్ హెల్పింగ్ ద సర్జన్స్ ఇన్ సర్జరీస్?
I'll take that question.
Yeah, please, sir.
See, conventionally we were giving big cut along the chest wall,
Okay.
meaning between the ribs to open and go inside and do any surgical procedure.
Correct.
Now, minimally invasive means we make a very small cut. Or sometimes it can be done only using endoscopes. We call it thoracoscope because it is entering into the thorax. So thereby we are limiting the size of the cut. So the pain is less, recovery is faster.
దానివల్ల సమ్ కైండ్ ఆఫ్ ఏమంటారు ఎఫర్ట్ ఫ్రమ్ ద సర్జన్స్ కూడా కాస్త తగ్గిందంటారా? డిడ్ ఇట్ హెల్ప్ యూ గైస్?
No, it will take more time because
Actually,
you are
it makes it
working
more difficult for them.
Yeah, it is minimal access. You want to do a complete procedure. So the certain conditions it is easy,
రైట్.
but not all conditions. In some conditions you need to make a big cut because if suppose you are removing a big chunk of tissue or a tumor, you need to deliver it out. So you need to make one cut at least much bigger.
రైట్. సార్ యాజ్ అ పల్మనాలజిస్ట్ సార్ మీరు ఒక పేషెంట్కి ఒక థొరాసిక్ సర్జరీ తర్వాత మీరు అందించే సపోర్ట్ ఎలా ఉంటుంది?
నో ఎసెన్షియలీ ఇప్పుడు నేను చెప్పినట్టు లోబాక్టమీ చేశారంటే పార్ట్ ఆఫ్ ద లంగ్ ఈజ్ రిమూవ్డ్,
రైట్.
వెదర్ ఇట్ ఈస్ డిస్ఫంక్షనల్ ఆర్ డిజీజ్డ్ or containing a tumor or something. We have removed effectively, say, let us assume about 15% of the lung on one side. So functionally he is going to feel a little disabled or feeling breathless because he is used to a little better function, okay, before the surgery to after the surgery. So where we can help him is rehabilitate his lung function, optimize his lung function, strengthen his muscle power and other things, so that over a period of time he gets over his disability, gets back to his normal useful routine in spite of the surgery. Ideally what we do is, most of it is done before the surgery also, so that you build up his lung reserve and keep it to the optimal level before he goes in for surgery. Because everybody's got lung reserve, good amount of reserve. Most of us don't use it. All right. Now, supposing I ask you to run 100 meters dash, I'm sure you won't be able to do it if you're not used to doing it on a regular basis.
Correct.
But if I give you 1 month time to exercise and get into that,
I'll work on it.
you will work on it.
Correct.
The same concept applies to before surgery.
Okay.
If you have the luxury of that time,
Right.
is to build up his lung function to an optimal level, so that he will be able to tolerate the resections much better without feeling the breathlessness that he is likely to feel after the procedure.
Okay.
So you optimize the lung function before you subject him to surgery.
సో సార్ యాజ్ పల్మనాలజిస్ట్ మీ దగ్గరికి ఒక కేసు వచ్చినప్పుడు మీరు దీనికి సర్జికల్ ఇవాల్యుయేషన్ కావాలి అని మీరు ఎప్పుడు అంటారు? అంటే ఆన్ వాట్ క్రైటీరియా?
Now, one thing is, I have to decide whether the case which has come to me is medically treatable or requires surgical help. That is the first decision. Now, if it is a surgical case, purely a surgical problem in the thorax, then I have no business dealing with it. I straight away hand it over to the surgeon.
రైట్.
But if there is some kind of an overlap, if somebody comes with say a disease like, for example, bronchiectasis antammo. When he comes to me, he is sick, he is infected, he is having a fever, he is run down, nutritionally in a very poor state. Even if I send it to the surgeon, he'll say, hey, come back when you're better.
Correct.
So my role comes in to build him up to that level where he can withstand the surgery, and at that point of time hand him over for the surgery when he is dry, not infected, no fever, nutritionally well done, and that's when he takes over.
Correct.
So when we work in tandem, the results are definitely going to be much better.
Correct. Absolutely.
And that's the way to look at it. So it's a complementary job. It's not that pulmonologist is doing his own independent job and CT surgeon is doing his own independent. No. It is always a complementary thing. Before, during,
And
after. It is always a complementary thing.
సార్ మీరు ఆఫ్టర్ అన్నారు కాబట్టి ఐ వాంట్ టు ఆస్క్ యూ సంథింగ్. ఈ సర్జికల్ అవుట్కమ్స్ లో ఈ పల్మనరీ రీహాబిలిటేషన్ అనేది ఎలాంటి రోల్ ప్లే చేస్తుంది?
That's exactly what I'm talking about.
కరెక్ట్.
Rehabilitation into what? For a person who is unable to do something, you're training him to start getting acclimatized to the new reality of his lung function,
రైట్.
so that he is able to utilize his lung to the optimal level and go about his normal life
ఓకే.
with the least amount of disability.
సో మీ ఇద్దరు మనం ఇక్కడ ఉన్నాం కాబట్టి గివ్ మీ వన్ ఎగ్జాంపుల్ ఆఫ్ హౌ దీస్ టూ ఫోర్సెస్ కేమ్ టుగెదర్ ఫర్ ఫర్ అ బెటర్ అవుట్కమ్ విత్ రిగార్డ్స్ టు అ పేషెంట్. ఏదైనా ఒక ఎగ్జాంపుల్ చెప్పగలుగుతారా సార్?
There will be multiple, like suppose before surgery, he'll investigate, he'll come to a conclusion, surgical cases come to me. Post surgery also sometimes I need their help.
Right.
Sometimes there can be mucus plugs, there can be a lung collapse immediately after surgery. They don't recover so easily. So we talk to him, he'll do a bronchoscopy, clear the airway completely so that the remaining lung will open up completely.
ఓకే.
So that's one thing. And polytrauma, multiple injuries,
Okay.
tracheal injuries or they can do a stenting that will make things easy for us.
Can you add something to that, sir?
Yeah, absolutely. That's what I said, it's complementary.
Okay.
There are certain things which they don't do
Okay.
or they can't do in an emergency
Okay.
because the patient is too sick to be taken up for a major surgery.
Okay.
So we act as a bridge.
Okay.
Like for instance, he says there's a tear here. Patient is in very poor general health.
Right.
What do you need? You need to stabilize him.
Correct.
And that's where we are there.
Okay.
We stabilize him, if necessary, put a stent. All right?
Correct.
So that he breathes normally. He continues to go on. Build him up. Maybe in a week or something, he'll do much better. That's the time for him to go in for surgery.
Correct.
You take him up immediately, he's a very bad risk or a very high risk. But you stabilize him, optimize everything, and then send him for surgery. Your results are much better.
Correct.
So it's always that, I hold his hand and he holds mine.
Right.
Whenever it is necessary. It's not a question of who's the surgeon, who's the pulmonologist. Who's the right person for the right situation there.
Correct.
That's it. That's more important.
Sir, ఒకవేళ if a patient walks in and joint గా మీరు evaluate చేసిన తర్వాత comes out that he has a lung tumor or something. ఈ మల్టీ డిసిప్లినరీ పాత్వే అనేది కేర్ హాస్పిటల్ హౌ డస్ దట్ లుక్ సార్ ఒకసారి మాకు చెప్తారు.
See, when it comes to your tumor, he comes in only after the diagnosis.
Okay.
We are the people who normally work it up to the point that we have a precise diagnosis.
Right.
Whether it's a lung cancer or it's a benign tumor. If it's a lung cancer, whether he is amenable to surgery or not, we do all the staging, okay, by doing a lot of diagnostic studies, EBUS and TAMO. I mean, multiple various ways of doing things. Once we categorize the tumor and say that, okay, this man will benefit from surgery, this in conjunction with the oncologist, we will sit down, decide, and hand it to the surgeon, who would also be part of the discussion, saying that, okay, this man has got stage 2, I think we can get away with the surgery. We can remove this part of the lung and he will survive even if we remove that part.
Right.
So that's what is more important. So multiple teams may not be sitting across like in a table like this, but I talk to him, we all talk together, everything is documented, everything is seen. So it's always a how do you say, cohesive approach to an individual.
Right.
That's what is required.
It's like a tumor board
Yeah.
where the oncologists are involved, radiologists are involved, pathologists are involved, thoracic surgeon or oncosurgeon, and of course pulmonologist. So make a plan of what suits that particular patient best.
And the complications that you foresee, how do you fix that, sir?
See, complications ante every procedure has got some known complications. We try to minimize them.
When you say known, such as?
Ante they're all inherent to the procedure.
Right.
For each procedure is different.
Okay.
Okay. Now supposing for an example, let's not even go up to surgery.
Right, sir.
You're trying to anesthetize a patient.
Okay.
He has a violent reaction to a drug.
Okay.
So even before the surgeon is anywhere close to him,
Okay.
patient is having a massive problem.
Okay.
So these are all things which are anticipated, thought of, you're prepared for it, and keep everything ready for that. Similarly for everything, whether I do a bronchoscopy as a diagnostic procedure or whether he is doing a resection for a tumor, there are inherent known described complications for every procedure.
Right.
And we need to be prepared for that. So, as I said, keep silent for about 5 minutes or 10 minutes in the morning before you come to the hospital. Similarly, even before you approach a particular patient, before laying your hands on him for any procedure, I'm sure you have mentally done that surgery in your mind before you have touched the patient.
Correct.
Okay? That's what it is all about.
సార్ లంగ్ రిసెక్షన్స్ కి కానీ లేకపోతే చెస్ట్ ట్రామాకి సంబంధించి కానీ ఈ మధ్య కాలంలో వచ్చిన న్యూవర్ సర్జికల్ టెక్నిక్స్ ఏంటి సార్?
Lung resections, yeah. Earlier it was either a lobectomy or a pneumonectomy.
Okay.
Resection means removal of a part of it.
Correct.
Rarely we used to do non-anatomical resections for some peripheral lesions, peripheral means on the outer side of the lung. Nowadays, people are doing sleeve resections, meaning lung tissue conserving surgery.
Okay.
If suppose there is a problem somewhere in between the upper lobe and lower lobe in the bronchus, we remove only that segment of the or a particular lobe and reconnect rest of the tissue, so that more functioning tissue is retained inside. Or segmentectomy, only a part of the lobe is removed. This, when it comes to the lung resections. When it comes to the chest wall, the most common thing is injuries. We come across fracture ribs. Earlier, when there are multiple fracture ribs, flail chest, we were not proactive in fixing them. We used to put them on a ventilator, give adequate analgesia, painkiller. So it used to take time. Sometimes we could not remove the ventilator from the patients, especially elderly. Now we are fixing them. More number of plate and screw fixators are available now. So we have the titanium available. If it is expensive for a given patient, we can even go for stainless steel. So that any ribs more than 3 rib fractures consecutively, we call them flail chest, when the same rib is broken in more than one place.
Okay.
That segment moves paradoxically.
Right.
So that will hamper the respiratory dynamics. Okay. So we fix it. Like that, if suppose sternal injuries are there, the sternum is gone. Earlier we were putting the muzzle, we are sliding the muzzle and giving a cover. Now we can make a custom make design of that defect using a template and making a titanium plate and then fix it there. Give a cover to the heart and other structures. So these are newer additions.
Wow. When you're saying నేను ఊహించుకుంటుంటేనే అసలు such great innovation అనిపిస్తుంది.
It's a part of our technological advancement and using in a better way, that's it.
సార్ ఈ జనరల్ ప్రాక్టీషనర్స్ కానీ ఫ్యామిలీ డాక్టర్స్ కానీ ఇందాక మీరు చెప్పినట్టు వీళ్ళు చాలా మంది మిమ్మల్ని రిఫర్ చేస్తారు కదా, ఓకే, అలాంటి జనరల్ ప్రాక్టీషనర్స్ ఆర్ ఫ్యామిలీ ఫిజిషియన్స్కి మీరు ఇచ్చే అడ్వైస్ ఏంటి?
GP is a very essential part of medical practice. But again, with a rider, don't retain a patient for longer than necessary. If after a week or 10 days or a reasonable period of time, something is not settling down, it's time for him to refer to a higher center.
Correct.
Right? If you are able to follow that diligently, very few mistakes would be committed. Nobody does that by design, but knowing that, yeah, it will settle down, let us give it another 2 weeks. But that usually delays the entire process. Okay. So as long as you're working within your known limits and your limitations actually, then you're good. I would love to have such a GP.
Oh,
No, because it will cut down half my work of doing unnecessary tests.
correct. Correct.
So that's where it is. So essential part of the system, but again, person who knows his limitations.
Correct. సార్ ఇప్పుడు కేర్ హాస్పిటల్స్ బంజారా హిల్స్ దట్ వీఆర్ టాకింగ్ కదా, కేర్ హాస్పిటల్స్ బంజారా హిల్స్ లో ఈ కొలాబరేటివ్ కేర్ అట్లీస్ట్ వెన్ ఇట్ కమ్స్ టు చెస్ట్ డిసీజెస్ ఇది ఎలా బిల్డ్ అవుతుంది అంటారు?
See, I'll tell you, I run a primary outpatient service here. So we do tend to have a lot of walk-ins who come on their own. Whether it's a cold or a cough or something, they think they can walk in straight. Those are the kind of people who can be looked after very well by any GP. They don't really require a specialist. Here we're just trying to educate the people, the GPs also. And so when a person really requires a specialist care, once they do that, I think we are much better off. We'll be less burdened with the routine and be able to spend more time for people who really require it. That's the way I would look at it. I'm sure he has his own viewpoints on that.
The collaborative care.
Suppose if a patient is having respiratory failure or ARDS, we call it, total white lungs, in spite of putting him on ventilator, he may not improve. We put them on a machine called ECMO. So there we need their help every day.
Correct.
And suppose we go for some kind of a bronchoplasty or lung transplant, we need their help. We need bronchoscopy every day to see the anastomotic site, the secretions inside, everything. Or some difficult situations where there is a condition called pulmonary thromboembolism. So, if treated, there are two options. Either we go for a very major surgery called thromboendarterectomy, or they end up in lung transplant.
Okay.
Even the surgery has its own issues. Post-surgery, sometimes they get into reperfusion injuries. Definitely, we need their help.
Yes.
So,
I'm sure there's a lot of collaborative work to be done.
yeah.
Oh yes, it all.
These are high-end works other than the routine.
Routine work anywhere
Anywhere can be done.
Yeah.
Yes.
All right, sir. Now I have an interesting round. It's called the Rapid Care Questionnaire. So you have to answer it in a word or a line. Yes? So ready, both of you? Yeah, sir. Let's go. The most common non-cardiac chest surgery.
Lobectomy.
Okay. One symptom that one should never ignore.
Blood in your sputum on a regular basis.
Surgical or bronchoscopic. Your first choice of lung biopsy.
It is bronchoscopy.
It's always
nowadays.
bronchoscopy.
Bronchoscopy.
Always.
Okay. Biggest myth about lung surgery.
The chronicity and suffering is no longer there.
It is not such a scary surgery. It is extremely beneficial.
Open surgery or minimally invasive. What's your preferred route today?
Depending upon the condition
Okay.
and the stage.
Case dependent.
Okay. Breath or beat? What's tougher to stabilize?
Beat means the cardiac
Breath,
Yeah.
breath
Yeah,
or
yeah.
beat.
beat. Definitely heartbeat. Because arrhythmias are more complex. Multiple types will be there.
Okay.
Each has to be attended differently.
One word to describe teamwork between CT surgery and pulmonology.
Indispensable.
Absolutely.
Absolute indispensables. Yes, so thank you so much, both of you. అంటే collaborative care at Care Hospitals Banjara Hills అన్నది ఎలా ఉంటుంది అనడానికి this is the clear cut example. So thank you so much, Dr. Jayachandra. Thank you
Thank
so
you.
much, Dr. Nageswara garu. ఈరోజు we understood a lot of things. In fact, ఇలాంటి ఏమంటారు going forward ఇలాంటి lot of talks జరుగుతాయి for us to have a clearer picture. But thanks again, sir. Thank you so much.
Thank you.
Right.
Thank you.